Back to basics again, and my topic today is interpreting an antibiogram. I'm actually dividing it into 5 parts. One is discussing definitions, types and utility, methodology issues, intrinsic resistance, how we decipher common resistance mechanisms, and site-specific examples. So what exactly is an antibiogram? By definition, it is a result of lab susceptibility of an isolated bacterial strain to different antibiotics. Essentially, it's an in vitro susceptibility test. You have 2 types. One is the hospital antibiogram and the other is a patient-specific antibiogram. The hospital antibiogram is a periodic summary of antimicrobial susceptibility of local hospital isolates. It provides percentage susceptibility of organisms. It's used to guide empiric treatment, and that's really the main purpose of it. It is also used to detect and monitor antimicrobial trends. So when we look at antimicrobial therapy, it's actually divided into 3 parts. One is prophylaxis, where the risk is minimal, but we just want to cover. The second is empiric therapy, that is the best guess based on site, etiology, severity of illness, local susceptibilities that has been underlined because that is so important, comorbidities, the ability to source control, and also the history of previous antibiotics in that episode. And the last is defined infections, which is actual interpreting a susceptibility report. So the hospital antibiogram that all of us are familiar with essentially deals with empiric therapy or guides empiric therapy, and you have a patient risk stratification which depends on patient type 1 who has no contact with healthcare system, the ones who have some sort of contact with the healthcare system, and the ones in ICUs who are usually long hospitalization and have invasive devices within the last 60 days. Again, to reiterate, empiric therapy is early institution. We know in sepsis delay increases mortality, and blood culture sensitivity decreases with prior broad spectrum antibiotics. With these 2 tenets, we need to remember that the choice depends on the likely etiology and the local epidemiology, severity of illness, prior exposure, and comorbidities or risk factors. The second point of an empiric or antibiogram is monitoring trends. All of us are plagued with increasing antimicrobial resistance in hospital-acquired gram-negative infections with ESBLs, AMP-C, and carbapenemases, and antimicrobial resistance even in the community, E. coli, especially in urinary tract infections, and Staph aureus, CA, MRSA, and we're certainly seeing a rising incidence of azole resistance in Candida. This was a good study that was published last month, which actually puts into perspective what we're all facing, and this was in almost 4,000 non-repetitive blood culture isolates that were subjected to susceptibility testing, and no surprises here. If you look at the susceptibilities of Enterobacteriaceae from the critical care unit, all of us are facing the same issues here. With E. coli and Kleb, you can see there is a huge amount of ES. Look at the blue lines. The blue lines are ceftazidime, which would reflect to an extent the ESBL production. And look at Klebsiella pneumoniae and look at its percentage susceptibility to the carbapenems, as you can see the green line in the last slide, which is showing that it's slowly decreasing. In this particular issue, it had actually fallen to 40%, which is quite scary. So let's come to looking at defined infections and the actual focus of interpreting a susceptibility report. We have many methods. You have the MIC, the disc diffusion, and I'm just going to touch on clinical breakpoints. So these are the methods. All of you are familiar with disc diffusion, which can be done either by Stokes or the Kirby-Bow method. Dilution MIC, which is broth dilution or agar dilution, and that little plate shows you wherever there's clearing, that would be the MIC, and the gradient diffusion is the E-test. And you can have manual methods, which we've discussed just now, or automated microdilution tests if you have the money. Microscan, Vitek, and Phoenix are the ones doing the rounds. So MIC or minimum inhibitory concentrations would define, in this situation, we would put a known quantity of bacteria into each tube at various dilutions, and the lowest concentration that results in inhibition of visible growth is the MIC. So here you can see the MIC is probably here, you can see it at 4 rather, it's isolate dependent and variable. Similarly, remember the zone diameter is inversely related to the MIC. The larger the zone diameter, the lower the MIC. And for how do we define this? We actually don't have to worry about it, but disk diffusion diameters, you construct scattergrams of zone diameters versus MICs. These are the automated methods that are doing the rounds, and all of us today, most of us in India have some sort of automation which provide an expert interpretation of our susceptibility tests. And the methods include broth dilution, broth microdilution, as I've told you earlier, agar dilution, and E-test, which is a gradient diffusion MIC. The limitations of broth microdilution or the automation methods are, you tend to have limited dilution series. You would only have probably sometimes only two concentrations, the susceptibility and resistant breakpoint. And then sometimes in some systems, the growth characteristics may not actually represent true MIC values. MIC is the only valid AST methodology in certain situations, and we need to remember this, that there are no valid disk diffusion criteria here. For example, colistin for Enterobacteriaceae and Acinetobacter, there are no disk diffusion criteria available. We have to do MICs for colistin and say E. coli, Kleb and Acinetobacter. Similarly, we need to do vancomycin and daptomycin MICs for Staph aureus, levoflox for Burkholderia, and I'll be discussing the rest subsequently. So now, look at it this way, MICs and disk diffusion zone diameters are really meaningless unless you have something to apply them to. And these are what are known as the clinical breakpoints, which indicate the likelihood of therapeutic success or failure based on micro findings. And the concept of clinical breakpoint is essentially based on three parameters. These clinical breakpoints are actually set in stone. We have nothing to do with them, and they are usually sort of formulated when the antibiotic is launched, and they are based on wild type distributions, the PK/PD studies that are based on serum levels, and clinical trials most importantly, which would define the efficacy and outcome data. So look at this chart, it would show you the clinical breakpoint. You would have a susceptible clinical breakpoint and you would have a resistant clinical breakpoint, as you can see here. Now, what are these breakpoints? They actually distinguish what is treatable from non-treatable, and as resistance mechanisms evolve over time, we need to revise these breakpoints. For example, Enterobacteriaceae for cephalosporins and recently for the carbapenems, and Salmonella for the fluoroquinolones such as ciprofloxacin. So to kind of get a perspective on this, what is the MIC breakpoint and what does it do? This slide is important because it really puts into perspective what I've been telling you. It is the achievable drug concentration at the site of infection. The MIC breakpoint characterizes the organism's MIC as susceptible, resistant or intermediate. Various antibiotics have different breakpoints, and the MIC of the patient's isolate should be less than the MIC breakpoint for it to be called susceptible. So, I'm going to ask you this. If you have a pathogen in your patient, and we have tested the MICs to 4 antibiotics, what would be the best drug to use? Here you have an antimicrobial ABCD, and you have these MICs 8, 4, 2 and 1. I will ask you, what would you think intuitively would be the best antimicrobial to use? Most of us would jump at what will seem the lowest, that is 1. But to be honest, and sort of to reiterate, it's not just the patient's MIC that counts. You actually have to plug in the MIC breakpoint, and this is again to reiterate what I just said. So when you plug in the breakpoints, you will find that 8 was the only one that was sufficiently, 8 and 4, that was sufficiently lower than the MIC of the patient's organism, that was sufficiently lower than the MIC breakpoint for that particular bug. So in essence, A stands to be the most appropriate antibiotic that you would give, and D, that looked like the best, is actually resistant, because the MIC of the patient's organism is more than the MIC breakpoint in that situation. And this is how a good report should look like. You have the sample from where it is drawn. This was a E. coli that was positive from the patient's blood culture and urine culture, and you have the patient's organism's MIC, you have the MIC breakpoint, and you can interpret for yourself what is sensitive and what is resistant. So you have to have a lot of information on your antibiogram to actually ascertain whether it is susceptible or resistant. Now let's understand it a little more in practice. I have this 21-year-old female who complains of dysuria and frequency. The urine analysis shows pyuria and nitrate positive. She is empirically given amoxicillin and the culture grows out E. coli. Amoxicillin 2 days later comes out as resistant, and the patient meanwhile comes to you with a report and says, doctor, I'm absolutely fine. The first thing to do is say, oh, the lab is wrong. So what went wrong in this situation? Let's look at it this way. Antibiotics have different serum, urine and CSF levels. This is just sort of putting into perspective what would be the CSF level, what would be the serum level, and what would be the urine level. Now let's look at isolate 1, 2 and 3. Each has different MICs. Now we're talking about isolates. The ones in dots are the break point for that antibiotic. And these are the isolates. Isolate 1 has an MIC of 4, isolate 2 has an MIC of 32, and isolate 3 has an MIC of more than 128. What this means is that you actually have to look at the interpretation at various sites. Isolate number 1 would probably be resistant in CSF because the organism MIC is higher than the CSF breakpoint. Isolate number 2 would be resistant in the serum, and isolate number 3 would be resistant in CSF. Unfortunately, this world is not perfect, and concentration of antimicrobials, this sort of shows you concentration of antimicrobials at various sites. Ampicillin at a standard dose achieves an MIC of 32 micrograms per mil. At an MIC of 32 micrograms per mil is still effective for treating bacterial cystitis because the bladder concentrations is 600, whereas if you look at the serum concentrations, they're just 2.5 in this situation. So interpretive MIC breakpoints are selected on serum breakpoints for in vitro susceptibility testing, and here we wouldn't take into consideration that this particular antibiotic concentrated in the bladder and so was able to eradicate the infection. So the report would read as R, as it did, but the patient did well. The issue here is that most Indian labs follow the CLSI guidelines that doesn't have urinary breakpoints. The BSAC, that is the British Society of Antimicrobial Therapy, actually has breakpoints for urine. Has urinary breakpoints defined for these drugs. So remember that microbiology reports SI or R are projected to serum levels. They don't tell you what are the tissue MICs, and for the same bargain drug, there should be ideally in a perfect world different susceptibility standards for those that are isolated from the urine, from the bloodstream or from the meninges. So again because this is important that you remember this, susceptibility tests today are usually projected to serum levels. It assumes that the isolate has been recovered from the blood and exposed to serum concentrations in the usual dose. And if the drug concentrates in the urine or in the bladder, drugs termed as resistant in the serum may well be used for cystitis. So what are we saying? We are saying that susceptible means the strain can be treated with normal doses. The MIC is below the breakpoint. I is when it concentrates, and a higher dose can be used, for example, the beta-lactams and the quinolones in urine, and R is when it's just less than 16% predictive of success, and the MIC is higher than the breakpoint. I would urge you to be current, to make sure that the lab that is helping you with your antibiogram uses guidelines that are internationally based, CLSI or UCAST, and check that the latest updated version is used. For example, this is how the guidelines would be. There's an MIC breakpoint and a zone diameter as well. And CLSI is one of them. This is the latest as far as this year is concerned. You have UCAST guidelines that are available freely on the net. And the situations when you are advised to do MIC testing are in serious infections such as endocarditis, meningitis or endophthalmitis, sepsis, osteomyelitis, immunosuppressed patients when you're looking after them, prosthetic devices, or when patients are not responding despite as susceptible. There's something that you can take a little further. How sensitive is sensitive? Now look at this. If I were to ask you what is your MIC IQ here, what would you say was the best? These are E tests that are showing MICs, drug A, B, C, D, E. And if you look at this, it would show you that apparently D looks the best because it has a really low, again reiterating the same point, has a really low MIC. But if you look at this formula, which helps to sort of define what should be the expected efficacy, that is the MIC breakpoint over the MIC, you have C. And if you look at this chart, it actually shows you there's a big difference in the susceptible range from the breakpoint versus D, which has a much less difference here. Okay? Now coming to intrinsic antibiotic resistance. Intrinsic or natural resistance would define a lot of antibiotics with a lot of drugs. They're defined for the penicillins, the cephalosporins, which are intrinsically resistant to enterococci, rickettsia, and listeria. The carbapenems, I think each one of you need to know every word about the carbapenem, because that is our mainstay antibiotic in the intensive care unit, are resistant to MRSA, resistant to enterococci. It wouldn't be completely resistant, but meropenem is not so efficacious for enterococci, is less efficacious than imipenem. Stenotrophomonas, Burkholderia cepacia, and C. diff are traditionally defined as intrinsic resistance. Similarly, clindamycin is intrinsically resistant to Enterobacteriaceae and enterococci. You need to remember that because clinda is usually given as a gram-positive carb and enterococci are intrinsically resistant. And the polymyxins, again antibiotics we need to know every word about, are intrinsically resistant to the gram-positives, to Proteus, Serratia, Morganella, Burkholderia, Salmonella, and anaerobes. If you look at the selective pressure, today with more and more use of colistin or polymyxins, we're naturally going to select drugs in our intensive care units to which they're intrinsically resistant. And we certainly have started seeing an increase in Proteus and Providentia because, note here, they're intrinsically resistant to the polymyxins. Now let's look at how we can decipher common resistance mechanisms. This is how we would actually define MDR. MDR is non-susceptibility to at least one agent in 3 or more antimicrobial categories. XDR and PDR is just completely resistance, pan-drug resistant. Now these are the common resistant mechanisms that all of you are familiar with: decreased permeability, efflux, inactivation, and altered target. I'm only going to do one because I believe that this topic will be dealt with again. So let's look at inactivating enzymes. And this is the beta-lactamase family. And you have ESBLs, AMC, carbapenemases, and metallobeta-lactamases. And look at how you can actually from the antibiogram decipher whether this was an ESBL or not. Let's look at ESBL CTXM. Here you have resistance to 4th generation cephalosporins, susceptible to cefamycins such as cefoxitin, resistant to monobactam, susceptible to carbapenems and the BL-BLI combinations. From this susceptibility, you can intuitively say, yeah, this is probably an ESBL. What about AMC? AMC actually loses susceptibility to the beta-lactam inhibitors more or less. And there is cefepime that was sort of touted as being stable to AMC, but we're not seeing it in real life because of D-repressed mutations. And of course, you have the carbapenemases. And I think at this point, it's really important to mention that we in India cannot take advice from Western literature because our carbapenemases are not the serine carbapenemases such as KPCs. Our carbapenemases are essentially, majority of them are NDM. So the susceptibility patterns of NDM are completely different from those of KPC, and that's what we need to keep in mind. So challenges in interpreting the antibiogram, we need to remember changes in breakpoints over time, regional differences in susceptibility breakpoints, and of course inappropriately set breakpoints. I'm just going to give you some specific examples here. Let's take this case, an abscess with cellulitis, an 18-year-old who comes with an abscess and cellulitis on treatment with clinda and penicillin. The gram stain shows gram-positive cocci in clusters resembling staph. Do you need to change management? This is the susceptibility test. You're seeing pus, and you're seeing that this is a Staph aureus report, and these are the zone diameters. If I were to ask you one question, what is right or wrong with this report, or what, let's put it this way, what antibiotic is most appropriate in this situation? Would it be penicillin, ceftazidime, Cipro, Clox, Clinda, or Vanco? And I think here, certain issues have to be reiterated, and that is, this report is completely wrong. Why? Because it has zone diameters with these pluses against them. Zone diameters reading plus 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 lead to erroneous reporting and have no meaning in or of itself. I've just been talking to you all this time about interpretive breakpoints. that are derived from correlation between zone diameters and MICs. And look at this, the CLSI guidelines for staph show you that penicillin at a zone diameter of 28, that is almost 3 centimeters, is resistant. So if you were to go with 3 pluses, it would be wrong. And today more than 95%, 90 to 95% of staph are producing penicillinases that confer resistance to amoxicillin and even piperacillin. So in that report, of course, penicillin, piperacillin, erythromycin, once you plug in the interpretive criteria, is resistant, and of course Genta. There's something else you need to know when you're interpreting an antibiogram, and that is this inducible resistance, particularly to staph. Now look at this zone here. It looks like it's pretty sensitive, but if when erythro is resistant, you see a straight line next to clindamycin disc, and this straight line, despite the huge zone diameter, looks like a D, doesn't it? So this D is the so-called D test, and it is not only applicable to Staph aureus but to strep and strep species and strep pneumonia as well. So when you have Clinda resistance, remember you need to look for the D test. So of course Clinda and erythro as well. Erythro was anyway resistant, but of course Clinda. And remember, for Staph aureus, despite in vitro susceptibility, Cipro, Vanc, when I say Staph aureus, which is oxacillin susceptible, Cipro, Vanc and ceftazidime are not preferred agents for methicillin susceptible Staph aureus. And this, today we believe we are not only doing oxacillin, we are also doing cefoxitin. It's a surrogate for oxacillin. So in this situation, Clox is actually the best drug. If I were to sum up on Staph aureus, zone diameters, please remember when you see an antibiogram and the report reads 3 plus, 2 plus, it's something that you need to get back to the lab and say, look, I don't know what these 3 pluses and 2 plus mean, unless they have been sort of pitched in with a interpretive criteria. So they lead to erroneous reporting. Say vancomycin at a zone diameter of 13 is susceptible, whereas penicillin at a zone diameter of 28 is resistant. The reason is because of diffusion. These drugs diffuse well, whereas Vanc or highly protein bound drugs don't diffuse even in the media. Penicillin resistant oxosusceptible Staph aureus are resistant not only to penicillin but also to ampicillin, azlo and piperacillin. Ceftazidime and Cipro are not great drugs for staph. Clindamycin susceptibility must be validated by a D test if erythro is resistant. And for MSSA or methicillin sensitive Staph aureus, Clox is the best drug, followed by first generation cephalosporins, and Vanc really is actually an inferior drug. The second and last case is of meningitis. This was a patient who was an alcohol user, had fever and backache and was found unconscious in the bathroom. He had a high WBC count. The brain imaging was normal and the CSF showed a pyogenic picture. He was started empirically on ceftriaxone, vancomycin and ampicillin. When we did the susceptibility test, we found that oxacillin was resistant. And to be honest, remember that this diffusion criteria for strep pneumonia only exists for oxacillin. Oxacillin is the class representative of all beta-lactams. Oxacillin disc showed a zone diameter of 16 millimeters. When you see this, I would ask you, what should be done? Oxacillin is reported as resistant. Should you continue the current treatment? Should you change to penicillin? Should you do the MIC to penicillin or should you do the MIC to ceftriaxone? Our patient is on ceftriaxone, Vanc and listeria and ampicillin. Ampicillin can actually be dropped because we've confirmed that this is strep pneumonia, so the coverage for listeria may be discontinued. So you need to actually look at the MIC to penicillin. In this situation it was 1. And this chart is the current CLSI guidelines which show that for meningitis, the susceptible breakpoint is anything more than 0.12 is resistant. That wouldn't apply to non-meningitis sites such as pneumonia or bacteremia, even bacteremia, where the resistant breakpoint is so much different. It's 0.12 for the meninges and more than 8 for non-meningeal sites. What about cephalosporins? Should we need to invest a little bit more money and do his MIC to cephalosporins? Actually, if you have the zone diameter, as I showed you earlier, if it was susceptible in a zone diameter of 8 to 20, which it was in this situation, the oxacillin zone diameter was 16, remember? you can actually say it's going to be susceptible to the third generation cephalosporins, and you don't need to do an MIC or an E-test for the third generation cephalosporins. So the dichotomy in pneumococcus has somewhat been resolved for this particular organism because we have site-specific breakpoints. For meningitis, more than 0.12 is regarded as resistant. For pneumonia, more than 8 is regarded as resistant. So take-home messages on strep pneumonia would be different clinical breakpoints for meningitis and pneumonia. Disc diffusion criteria exist only for oxacillin. If oxacillin is less than 20, you have to do an MIC to penicillin. If oxacillin is more than 8, ampicillin, amoxicillin or third generation cephalosporins can still be used. Strep pneumoniae does not become resistant with the beta lactamase unlike staph. It's due to an altered penicillin binding protein. So you shouldn't actually report or expect that a beta lactamase inhibitor will help. And in severe pneumococcal infections, we feel that combination of a beta lactam with a macrolide is preferable. So friends, briefly to summarize, I think it's important that we understand the utility of an antibiogram. We understand how to interpret it. We understand the methodologies. Is MIC disc diffusion or preferable? And what exactly are these clinical breakpoints? You must understand that a clinical breakpoint is completely different from the patient's MIC. We're actually going to use the breakpoint to determine whether the patient's MIC is going to be susceptible or resistant. We must know what is intrinsic resistance. Tomorrow, even if a lab has reported an intrinsically resistant, like say they've reported Burkholderia susceptible to colistin, you need to know that because you are the treating physician. There may be a small zone diameter and some errant lab may not even realize this, but you need to know that. You must know about examples of MIC breakpoints where they can differ in site-specific examples. And I think also you must sort of have an idea on how to decipher common resistant mechanisms,